Everyone, afternoon and welcome to the Welsh Sexual Assault Services Lunch and Learn session. Croeso I sesiwn ginio a dysgu a ganhaulia gan raglen gwasanaethau Ymosodiadau Rhywiol Cymru. You'd think that my Welsh pronunciation would have got better the number of times that I've said that, but unfortunately it hasn't. So welcome everybody, I'm Jo Williams. I'm the Programme Director for Welsh Sexual Assault Services. And for this month's Lunch and Learn session, I'm really pleased to welcome Catherine Simpson, who's going to be giving us a session today on Paediatric Sexual Assault medical examinations. So I'll pass you over to Catherine to take over the session. Thank you.
Thanks, Jo. Right, is my presentation showing itself?
Yes,
lovely. And so initially this was going to be myself plus Claire Lippitz, but I think she's having a hell of a week, so she may appear and join in at some point. Jo, if you can keep an eye on the chat for me, because I might not be able to see everything, and if there's any sort of questions that come up in the chat. Also, if anybody can mute themselves, if that's okay. But you're very welcome to put a hand up or put a question in the chat as we go along, if that's okay. Thanks very much.
No problem.
So I'm Catherine Simpson. I'm a paediatrician based in Cardiff and Vale. I've got a role as the clinical lead of NSAF SARC based in Cardiff. And then I've also got a lead role within the Welsh Sexual Assault Services from the paediatric point of view. And I've been working within sexual assault services now for, well, on and off for about 10 years, but I've been sort of doing it as my main job now for the last sort of 3-4 years. So yeah, hopefully I'll be able to answer any questions or queries that anybody may have. So today's learning objectives really is to sort of go through what the role of a sexual abuse medical is. We're going to talk a little bit through some of the terminology that can be used in our safeguarding reports. I want to talk a little bit about sort of prepubertal and postpubertal differences, how we examine a child, and then I can talk a little bit about some sort of common dermatological skin conditions that can we sometimes see and have referrals regarding, and talk a little bit about the aftercare needs. And this session really is aimed at everybody, so it's not sort of, the idea isn't is to help people who aren't necessarily medical to understand what we're doing, and hopefully look at addressing any of those sort of myths around medicals and understanding when it's good to examine children. So as part of that, just a little bit of self-care, we are going to be discussing some anatomy and injuries, not in huge detail. We haven't got any photos in this presentation, but there are some line drawings. So if at any point you need to step out or turn your screen off or anything, that's absolutely fine. And if there's any questions that people want to ask after the date, then I'm happy to be emailed. So just to start off really is what the role of the CSA, so child sexual abuse medical examination is. So in the acute phase, so when we talk about acute, we normally mean within sort of 7 days of an alleged assault having happened. One of the big things is looking for forensic evidence, and that's looking for DNA swabs that then are processed by police and are used for evidential purposes. And those swabs are time limited. So depending on what the alleged assault was, there'll be a different time frame for where there is possible DNA evidence gained. And those time frames can vary between sort of 48 hours up to 7 days potentially. The other important thing is documentation of injuries in the same way as when children are referred for physical abuse safeguarding medicals by paediatricians. That's again part of our role when we see children in the SARC. We'll be examining top to toe, and if there are any injuries that are present, we'll be assessing those to see whether they are concerning with respect to them being possibly inflicted. Also sort of recognising that, abuse rarely comes alone within one category. Often if it's a type of abuse happening, then quite often we need to be looking for other things like emotional abuse, neglect signs, physical abuse signs as well. The other role in that acute assessment is thinking about any emergency healthcare needs. So that may involve emergency contraception if you've got a young person who has started having her periods. If we can also think about post-exposure prophylaxis for HIV. So if an assault is a high-risk assault and has been conducted by a high-risk person, then we can think about providing medication that decreases the chance of the HIV virus being passed on. And again, that is time limited, so that medicines can only really be given within 72 hours and is more effective the sooner it's given. And then hepatitis B is something else that we can provide some protection for. So up to 28 days following an assault, we can provide the hepatitis B vaccination, which does provide a small amount of protection. The other thing we do is STI testing, which isn't time limited. Importantly, we hopefully provide some reassurance for the child or family, because sometimes children and family have concerns that something, there's some dreadful injury, or that they no longer look normal, or lots of ideas that may be there that hopefully we can address and reassure on. We look at doing a holistic review of other health needs, and that may include mental health and onward referrals. We provide a report, as we would do for physical assault medicals, for social services and police. But the important thing to notice is that we are not in a position to really provide services for an acutely unwell child. So, for example, if you had a young person who had a severe injury with a break or an abdominal injury or a head injury, or they were severely intoxicated and disorientated, for example, their health needs, their emergency health needs would need to be dealt with as a priority, and that would need to happen within an emergency department. So we also provide historic examinations for children and young people. And I think sometimes this is the area where children don't get referred, because I think if people feel that if they've missed the boat with respect to forensics, that there isn't necessarily a role for us to be doing these examinations. But the advice that comes from the CSA Centre and from the Royal College of Paediatrics is that we can still provide value of a historic examination. So again, that might be documentation of injuries. Most of the time, a sexual assault does not lead to any injuries that are long lasting. But on occasions, if you've got a young person who is otherwise not going to be sexually active, there may be some findings on their examination which can provide some evidential value. Again, young people would benefit from having a sexual health assessment. Thinking about, do they need any swabs taken, or do they need bloods for bloodborne viruses? And those assessments for children under the age of 13 aren't going to be taken up within sort of Department of Sexual Health. The only place they would be seen is by a paediatrician who's used to doing these type of medicals. We can look at completing their hepatitis B immunisations. Again, really importantly, we can provide reassurance of any ideas or preconceptions or concerns that the child or the family may have. And again, it's that holistic review, identification of any unmet health needs, and provision of report through to social services and police. So I'm not sure how well that sort of projects, but that's a little illustration that comes from the Centre of Expertise on child sexual abuse, just showing all those different roles really with respect to an examination. And so the forensic part is one part of that sort of jigsaw. All those other things that we just discussed about are just as important, and the child can still benefit from them. I'm not going to play this video just because it's 10 minutes long, but I've put it in just if people want to watch it another time or access it on the website. But it's a video from the CSA Centre that was, I think, recorded in the Haven SARC in London. And it just gives a nice video of a review of the examination. And it's quite a nice resource to share with children or young people or families that are concerned. Just gives a bit of an overview. It's very just sort of child focused. So it's just quite a nice resource. So reasons for examination, just going back to the FFLM guidance. So the FFLM, for anybody who's not familiar, is the Faculty of Forensic and Legal Medicine. And that states a paediatric forensic examination will be required whenever a child has made an allegation of sexual abuse or sexual abuse has been witnessed, or when a referring agency strongly suspects abuse has occurred. So obviously with some young people, who may be pre-verbal for either their developmental stage or due to any developmental issues, they may not be able to provide a disclosure. And really importantly as well, disclosing what's happened or telling a professional or a loved person what's happened is really difficult. And often children don't disclose. We know that the number of children that come through to services who make a disclosure are the absolute tip of the iceberg, and the majority of sexual abuse is not disclosed. So we have to remember that children disclose in different ways. Sometimes it's through their behaviour, sometimes it's through drawings, or sometimes it can be we've got sort of concerns in other ways. The examination can't always tell you that something's happened. As I said, most of the cases where sexual abuse occurs, examinations are entirely normal, but it gives another opportunity to try and just think about that. And again, just following up on that, even when a forensic window has passed, then it's still worthwhile thinking about any health needs. So again, that's not meant to be able to be read, but it just gives you the link through to the documentation that we use to give us an idea about these forensic windows. So the link there, it's an open access web page on the FFLM website, and it goes through the updated guidance on when forensic evidence could be gained. So say, depending on what the assault was, so intimate touching, for example, would be 48 hours. An anal assault would be 72 hours, and a vaginal assault potentially up to 7 days. This isn't for you to feel that you need to know these things yourself, but just to have that broad sort of idea. And so if you've got a young person within sort of a 7-day period or so, we would recommend speaking to a forensic medical examiner or a paediatrician within the SARC, so that you're able to have those conversations and make a plan as to whether a medical is needed sort of urgently or not. So this is just an anatomy revision. Apologies if this is something that everybody knows already, but what we're looking at here, you've got the mons pubis, which is sort of the sort of mound of skin towards the front of the genitalia. We've got the clitoral hood and the clitoris, so towards that top of the picture, sort of outlined in pink. We have the folds of skin. So you've got the external folds, which is the labia majora, so majora meaning the larger, and then the labia minora, which are sort of the smaller folds of skin that are to the side of the vulva. And within that, then you've got your urethral opening, which you wee out of, and your vaginal opening, with the hymen being the fold of tissue within inside that. And then we've got the perineum, which is a little bit of skin in between your sort of vulva and your anal opening. So the hymen is something that we sort of focus in on a little bit and tend to have lots of questions about. And I think it's something that there are lots of myths and preconceptions about. So I think there are some people who sort of, it's no fault. I think it's probably sort of the magazines that we read back in the 70s and 80s, but the idea that the hymen is the sort of cling film piece of tissue that goes across the bottom of the vagina and then gets popped or broken with your first sexual experience, and it's really not quite like that. So it is a membranous piece of tissue. It's at that sort of entrance to the vagina. And it changes a huge amount through your lifespan. So we'll talk about it in a little bit more detail, but those changes happen with the influence of estrogen. And as we go into puberty, it changes in a way that allows you to be able to have sexual intercourse. This sort of idea of it being broken, it can be damaged and it can show signs of injury, but it's not this sort of discrete sheet of something that's, you know, is broken and left sort of behind. When we talk about the hymen and when we talk about injuries, we often use a clock face description. So again, if you imagine that sort of picture from earlier on, the 12 o'clock position would be sort of pointing upwards towards the sky, so sort of the pointing up towards the belly, and the 6 o'clock position would be pointing down towards the bottom. Just to confuse things, the American clinicians will describe things depending on which way up the person is. Yeah, for any reports in the UK by a UK doctor, you should be that we're sort of conforming to this idea. So I've already discussed that a little bit. The important thing really when we talk about the hymen, and especially in prepubertal girls, is that the hymen is highly sensitive. So we can't touch it with a swab, which makes it sort of more challenging to examine at times. And then another point that's important is that in the research that's been done examining normal, population of children, there's no evidence to suggest that a hymen can be absent, just sort of congenitally absent. So for the prepubertal hymens, the main configuration we see is either an annular, which is sort of a donut shape, where there's sort of a bit of tissue all the way around the circumference, or crescentic, which is like a horseshoe. So those are pictures sort of A and C on that little group of pictures. That's the most common sort of configurations that we see in prepubertal children. So the outline tends to be quite smooth. So what we're looking for when we're examining is any evidence of any bruising or cuts or bleeding, or any evidence of scarring within that sort of circumference. When a young person moves through into puberty, it all gets a little bit more complicated. So in respect of what I was saying a bit, the changes are being made in order to be able to allow sort of consensual sexual relations as you get older. That hymen becomes less sensitive and it folds, so it becomes like a hair scrunchie, which makes it difficult to be able to see the edges. So when we're wanting to be able to see all these edges all the way around to see whether there's any sort of injuries, you can see sort of when you're looking at that scrunchy picture, you can't see what's in the depths of there, and there could be sort of a mark or a scar or something like that you can't see. So when we do the examinations in the pubertal child, what we try and do is visualize all around all those different folds, which can be a little bit more challenging. But most cases, the hymen by now is not sensitive to touch, and that means we can use different methods of doing it. I have noticed quite often we do get with the sort of tweens, they've got this sort of fimbriated hymen, but unfortunately it is still sensitive. So I'm always very cautious if we've got this, sort of a 12, 13-year-old, just to be very mindful of, if they're unable to, if they're able to tolerate you touching the hymen or not with a swab. And if they can't, then we stop, because the last thing we want to do is cause any pain or discomfort. This is just a very quick illustration of some of the different sorts of hymen we can see. It's not really sort of anything to know in detail, but you can have changes where you have a sort of a little bit of tissue going across that makes like a septum. You can have some changes where there's only a very small hole through the middle, or where sometimes where it is an imperforate hymen, where it is this discrete bit of tissue going right the way across. But that's unusual, and that would be something that would need to be dealt with if it was still present hitting puberty, because then you wouldn't be able to pass any sort of losses from your period, and that could cause medical problems. But it's very unusual, I've got to say. I've not seen it. So just to talk a little bit through the examination. So when a young person comes for examination, I think that the important thing to sort of warn the young person about is that it does take a while. Often people are here for a good hour and a half, 2 hours really in total. The first thing that we do is that we speak to the attending professional, be that a police officer or be that a social worker, to get that information of why they've come to see us. We don't want the clients having to repeat their story multiple times and sort of have any sort of re-traumatization in that respect. So sometimes all we've got is the first account that's been taken from the police. Sometimes there may have been the ABE, the Achievement Best Evidence interview already conducted by the police officer, or sometimes it will be the information gathered already from the social worker. It's helpful for us to know any factors around the alleged offender, which may change our risk assessment for HIV and hepatitis. So, for example, is it a person who's known to be an IV drug user, or who is from a country with a higher incidence of HIV, for example? It's helpful for us to know in acute cases if any early evidence kit's already been done. And it's also helpful for us to know whether sometimes it can be that a young person has already been taken to have the contraceptive pill prior to them disclosing what the sexual assault. We also sometimes have referrals come from the sexual health department where they've gone for emergency contraceptive, for example, and then disclosed actually the reason they're there is because of an acute sexual assault, more so in sort of the adolescents. So we would then move to talking to the family. So we'd be in one of our waiting rooms, obviously with some privacy. We say we wouldn't want to re-traumatize them by going through the detail of the reason they're there, but there may be some specific questions that haven't been covered within that first account or within the ABE, which we might try and clarify. And that might literally just be, did anything happen to your mouth? Did anything happen to your bottom? Do you have any other injuries anywhere else that we need to look at? And then we would talk through the examination. So we would go through details of what we're hoping to do. We would make sure that we highlight that they can stop at any time. If there are any bits that quite often when you talk through, the young person might say, "No, that's not happening." So it might be at that point that we would have a discussion about whether there are any alternative ways of doing it, or find out what specifically it is that young person's worried about, and see if we can either reassure or, as I say, work out, and if they're absolutely adamant that that's not happening, then it's not happening. I think these are young people who have had control taken away from them, and as much as we all obviously want to try and gain as much evidence to try and hopefully have a positive outcome in court, for example. It's really important that if we say that you can say no, then they can say no, and sometimes we can work around things in different ways. So it might be we can look at self-swabbing, where we sort of give some instructions to the young person and they go behind a curtain, they swab the area, they hand the swab back to me on the other side of the curtain. It's not as good, but if it's that or nothing, then we'll go for that. And often from a forensic point of view, often the evidence I think is gained from things like the early evidence kits and maybe the underwear or the bedding or things like that. It's the actual swabs that we take from the physical examination aren't necessarily the ones that give what you need sometimes. So once we've had the consent, we go into the examination room. So depending on whether it's an acute or a historic examination, the rooms will be a little bit different. So because of the forensic accreditation process, there are really strict rules around what the environment is like, and that people should be wearing DNA-free clothing and PPE. So all those things would be discussed with them before they go in. And we tend to make a bit of a joke of it, as you're going to laugh at the ridiculous outfit I'm going to be wearing next door, all this sort of thing. The rooms are quite clinical, but again, we discussed that beforehand. And then when we go into the examination, we tend to start the examination with the non-threatening things, the things that they may be used to from going to GP, of listening to your heart, looking at your nails, looking at your ears, and that gives you a chance to build up a bit of rapport and have a good chat. And it helps build towards sort of the bit that maybe they're more anxious about. We don't tend to strip everybody off all in one go. We can sort of work around either putting a gown on and just sort of revealing a small part at a time, sort of maintaining dignity as best we can all the way through. And then when we actually do the gentle examination, it's a case of just lying back on the bed, propped up on a pillow, and then a frog leg position. So where you have your feet together, pulled up nice and close to where your bottom is, and just relaxing your knees out to the side. And then either the gown or a towel is over the knees. So again, it's only sort of the view is only visible for the examiner at the bottom end of the bed. And again, with lots of explanation and chatting and taking time, majority of children tolerate this really well and are busy smiling and chatting or singing songs whilst this is all happening. So to say, with the prepubertal, that's the position we get into. Mostly we can see what we need to see with just observation. So they may be just having the hands very gently separating the labia, and generally that's all you need to do. So there's nothing going internal. We're not using any tools. We're not using any speculums or anything like that. Because I think quite often what I hear sort of describing medical examinations is, we wouldn't want to put somebody through an intrusive and untraumatic examination. And I really want to sort of, my big take-home point is it really isn't, because if it was intrusive and traumatic, I wouldn't be doing this job. So, we're doing it as the child is coping with it, and if they're showing any level of discomfort or any level of upset, we stop and we reassess and we see if we can do it a different way. So with the hymen in the prepubertal children, sometimes the inside margins of that donut or the inside margins of that horseshoe are kind of stuck together. And that then means it's quite difficult for us to get a really good view around the edge to see if there's any injuries. Sometimes we can get around that by changing positions. Sometimes we can get around that by using a little bit of saline that we can kind of squirt on. So it's not painful. It quite often makes them giggle, and they sometimes worry that they weed themselves. So you need to warn people beforehand what you're doing. But it's nothing that's uncomfortable. Usually then that allows us to see what we need to see. In some cases it's just not the day, and maybe you need to rearrange another examination at another time. For the post-pubertal child, again, it's very similar. So it's the same sort of position. With the swabs, if they're able to tolerate the hymen being touched, we would look forensically to try and take some swabs, if possible, from the lower part of the vagina. And with sort of the slightly older adolescents and teenagers, on occasions they tolerate having a speculum, and that allows us to take swabs from a little bit higher up. When we look at the hymen, again, it's a little bit more tricky because of all those folds. So either we go around with a little swab, just sort of trying to sort of delineate all the way around the edge. Sometimes we use a little catheter, so a catheter that people use for when people can't wee, and it's basically a long plastic tube, and it's got a little area at the end that sort of blows up into a tiny balloon. And what you can do is put that through that sort of central part of the hymen. You can blow up the balloon just a tiny bit, and that allows you then just to stretch that bit of tissue and to sort of stretch out all those little folds. And again, you explain every step of the way. If the young person says, nope, don't like that, you stop. But like that allows you to sometimes see what you need to see. So I'm not going to go into huge amounts of detail about this, but there is different terminology that is used depending on whether a finding is either acute or whether it's non-acute. So sometimes we talk about these lacerations or transections. In an ideal world, our reports should be written in a way that you don't need to have a medical degree to understand them, and they should all be our findings should all be easily interpreted. I have to admit, I suspect mine aren't always, but yeah, I do try and remind myself to do that. So the purple book is a reference document that is produced by the Royal College of Paediatrics, and it's also produced along with the Faculty of Forensic Legal Medicine, and it's pretty much the Bible of any paediatrician working within sexual assault medical examinations. It's an evidence review that goes through every sort of pretty much possible finding and looks at all the research papers, and then gives us a really good sort of evidence statement as to how significant a certain finding is. So it tends to be that we will sort of stick to that, really, because then it means that anything that we say, if we did sort of then, have to justify our findings in court, if it's not something that's kind of backed up with this sort of systematic review of evidence, would be hard pushed to really sort of justify what we're saying, really. Unfortunately, because of the nature of the work, there are quite often areas where the evidence is lacking. And then hopefully, again, in our report, we will sort of try and give an opinion and explain, those difficulties. I'm going to skip past these bits, I think. That's just a sort of drawing a little bit, just to sort of illustrate what we're talking about with potential sort of transections or lacerations. So it's when you've got a discontinuity within that sort of rim of the hymen. And so they're more significant when they're in the sort of posterior position. So that's between that 3 o'clock to 9 o'clock position. Obviously, if you're seeing any sort of acute bleeding or bruising, that's really significant in an acute case. Say sometimes you'll have a child who is seen for a historic examination where you've got sort of that finding, which can still be significant. Obviously, the tricky thing with a historic examination is then, attributing it to that, maybe that one alleged offence. But if you've got a young child who's not otherwise sexually active, then it's still significant. Yeah, so I'm going to skip that. So the main point really again on that is that you could have a person, they've done sort of follow-up studies where you have a young person who is seen with an acute injury and a significant acute injury, and then they're followed through and examined sort of 3 months or a year afterwards, I think it was, in the research, and that there were plenty of people who had complete resolution of the injury. So just because someone's had a really severe injury, or a very obvious injury, it doesn't mean that you're going to see it when it's when it's historic. So again, in our reports, we will always put a caveat. I think probably everybody I work with will always put a caveat in our conclusion when it's a normal examination of, a normal examination does not mean the sexual assault has not occurred. And we had a young person a couple of years ago who had a very serious penetrative assault that was witnessed, and they were seen within 2 hours and they had no injury, and nobody could quite believe that, but it was a really good illustration and reminder to us all sort of professionally, really, that it is true that you can have a very serious sexual assault with no injuries, and that does not negate the fact that it's happened. So that is just sort of following on from what I'm saying, really important take-home points that can take place with no injuries. They can heal. Injuries can heal very quickly, and they can leave sometimes a little notch, sometimes they can leave a little fold, and they can heal very quickly. So it's you're more likely to see an injury if we see them quickly. And saying the absence of signs doesn't mean the abuse didn't occur. I think the important thing as well, just to sort of note, which is something I only sort of quite got my head around a few years ago, that there's a difference between the legal vagina and an anatomical vagina, which seems a very ridiculous thing. But doctors and medical staff and I possibly other people assume that the vagina is sort of from the hymen upwards. But actually, the legal vagina, when you're talking about sort of penetrative events, includes the vulva, which is that sort of skin in between the labia minora. So you don't need to have gone to have been penetrated further up than the hymen for it still to be a penetrative assault. It's a technicality, but it's an important one. We do often see young children where there are concerns around some findings. And I think because of the nature of the work and people not wanting to get things wrong, we I think there can be a lack of confidence in people medically around examining genital signs, and so and being confident that it's something medical versus something inflicted, which is I completely understand. It is advised by the Royal College of Paediatrics that in the absence of any red flags, and the red flags being any sort of other social concerns or any disclosures, that ideally a young person should be seen by their GP or a local paediatrician to first ascertain whether it's a common dermatological skin condition that's causing the issue, rather than every child with a little bit of soreness down below needing to come to a SARC, because obviously it's that sort of balance of what's best in the best interest of the young person. But I appreciate that's not always easy, and I think it's quite often a case if people have got any inkling of concern around possible sexual abuse, then sometimes it ends up coming in our direction. So vulvovaginitis is something that's really common. It's basically a long word to say sore red genitals. It affects often the ages sort of 2 to 7. It can cause itching, redness, soreness, and pain. And sometimes there can be bleeding points where you've sort of been so sore and itchy you've scratched, you can scratch raw. Often the treatment is just by hygiene measures. Quite often the culprit can be, highly scented bubble baths and things that are drying the skin. And the treatment then is sort of avoiding of any sort of those things and applying some emollients in the same way as you might treat somebody with eczema, for example, and also avoiding constipation. So that's something very common that can cause red soreness, and on occasions there have been children refer to you with those concerns, but often the ones that refer to you have also got some concerns regarding maybe a family member or something like that. Lichen sclerosis again is less common, but does come in the direction of SARCs. It's really quite stark and impressive to see. So again, I understand why this gets referred to us in the SARC with concerns around possible bruising. If you've seen it and you know it, it's an easy diagnosis to make. But if, as I say, the first time I did see it, I thought, goodness me, that can't be right. It can lead to sort of what looks like bruising points and bleeding. But the sort of diagnostic part is that there's this area of pallor, of sort of pale skin that sort of forms a bit of a figure of 8. So it's something that occurs with that's impacted by estrogen. So it's something seen in prepubertal girls with estrogen levels are low, and also in postmenopausal women as well. It can be really sore and itchy, and the treatment is with strong steroids. So again, it's not uncommon to be seen. And again, if in an ideal situation, in the absence of any other red flags, that if that could be seen in a local service by a paediatrician, but I think it is dependent on whether you've got a paediatrician who's got that level of confidence in sort of diagnosing this type of things. Anogenital warts again, it's again can be something that's concerning from an STI point of view, but it's also quite common in young children. It can be spread by a range of different ways, either by what we call auto-inoculation. So, for example, if you had a wart on your finger and then you scratch your bum, then you're quite likely to end up with a wart on your bum. Sharing towels and things like that can also cause it. There was some research that suggested that 30% of anogenital warts in children is linked with child sexual abuse. And there have been some areas where they've had a pathway that every anogenital warts is seen by a SARC. And it doesn't seem to be coming out then that they are all, actually unveiling hidden sexual assaults. So I think it's a bit of a tricky area, that one. And I think, a case by case and looking at the looking at whether are there any other warning signs, are there any other red flags is important. Molluscum is another type of it's a pox virus. It causes these sort of lumps that can occur on any part of your body. They're sort of pearl-like with sort of a central dimple sometimes. In adults, they're classed as sort of a sexually transmitted infection, and they do see them in sort of the sexual health departments. Again, more often in children, it's auto-inoculation, and they're incredibly common. It's one of those sort of rashes that once you know what it looks like, you can spot it probably in about 50% of kids that you see just in a general paediatric clinic. And yeah, and they take a long time to go as well. So if a child has got them, it's likely they'll sort of crop up and pop up on their bodies over potentially a couple of years, just because they're so easy to spread and they're not easy to go away. Uncommon but important is you can have a urethral prolapse, and so that can be happen especially when you've got children who are sort of constipated or chronic cough, and that might cause some bleeding from down below. And then you can get some strange sort of hormonal changes that again can cause bleeding. Foreign bodies can cause foul smelling discharge. Again, it's important to sort of think about whether an object's been put up there just by a young child who's doing sort of developmentally normal stick things in a hole type behaviour, which isn't uncommon. But obviously, again, it's thinking about, are there any sort of sinister aspects to that? And then we can sometimes see people with injuries from what we call straddle injuries. So when you're sort of, for example, walking along a climbing frame and then you fall with one leg on either side and cause bruising to that area. So straddle injuries can cause quite significant injuries and bruising and bleeding. The important thing, as per any sort of physical assault medical, is is there a history? Has it been witnessed? Does it fit with examination? Are there any other concerns? So just sort of wrapping up really, the main sort of take-home points really is that the appearance of the hymen is something that changes over time within the same child. Penetrative assaults can occur and leave no injuries. That ideally injuries are best seen early, and importantly the clinical examination is only a small piece. As we're only a small jigsaw piece, and it's the important thing is what the child is saying, and all that other information that's being sort of brought in from intelligence, from police, and from sort of social services inquiries really. So I think that's pretty much the end. So I've put a few little references on there. So there's a link there to the CSA Centre website, which has got that video from the CSA Centre that's earlier on. It's also got a report that talks about the medical examination and the value of it, and takes into account the sort of the voices of children and young people and families with respect to them. Yes, there's a few other little sort of academic things there that might be of interest. Any questions? I'll stop sharing, I think. Any questions from anybody? Either type or put a hand up is fine. I've got Claire. Come on in there, Claire.
Thank you, Catherine. That's a superb overview, and I think really helps dispel some of the myths about examination. And I hope everyone's happy, whether an acute or a historic presenting child or young person, that they would seek advice about examination. A couple of things that you were saying about not repeating the history but checking from top to toe, I thought that's also relevant when we take swabs, either forensic or for infection. So often we'll take throat swabs even though there's no suggestion, because there hasn't been a disclosure of oral abuse, which is very similar to the principles around early evidence kit, but sometimes we do that, and we will do urine tests as well. So we're quite thorough in the checking in a fairly discreet way, but those investigations are also done, and that as part of that top to toe check, and sometimes can even prompt further information from the children or from the carers. So thank you very much. all the medical needs that come up are also there as well, and the fact that paediatricians sometimes see not just the little children but the post-pubertal children is really important, because there are things there that need to be done in terms of pregnancy testing and longer term follow-up as well. So sometimes the child needs the follow-up visit closer to home. So while I work in an Iron Bevan, so our children acutely will go to Cardiff SARC, but then their follow-up is local. So sometimes you've got more than one centre to deal with, and more than one doctor. So there's a bit of a changeover as the child goes through that care pathway. So that was the only other thing, that sometimes there's different health boards, different people, different doctors that pick up the care of the child.
I think, yes, so following from that as well, so just to be aware, so at the moment all the acute cases from South Wales and sort of West Wales come to us in Cardiff. The North Wales teams have got their own SARC there as well, that'll see acute cases. And then from a historic point of view, from a South Wales point of view, the Gwent team will see historic cases. Cardiff will see historic cases for Cardiff Vale and for Cwmtath. And then there is also a SARC within Swansea, the Swansea team. And so they're able to see historic cases from Swansea point of view as well. Right, so FGM. Right, so yes, we do see some young people with concerns around FGM. Not huge numbers, to be honest, but they do come through. Yeah, so again, it's trying to do that in a child-centered way. So occasionally it's sort of seen as an acute safeguarding concern. Sometimes it can be more from that sort of health check or a well-being check, with respect to checking for any health needs around, for example, any issues around their menarche or urine infections or anything like that. They are tricky because it's really important that we're only examining with consent, and sometimes that can be quite difficult to navigate when they're potentially sort of I think it's hard when people have been asked to come for an examination as requested by social services and police, and they want to be compliant with that. And that's quite a difficult thing to then match up with me taking a valid consent, because being coerced into being examined or feeling coerced into being examined versus actually giving valid consent are different things. So yes, they are tricky, but we do see them, and we've got a few that are coming through and the staff at the moment. And so you say sometimes it's around that kind of giving evidence from has something acute that's or criminal happened, or but I suppose my head mainly is thinking around the health needs and addressing any of those ongoing health needs. Does that answer your question? Just anybody else? Claire again.
I was thinking in terms of not just the FGM, but also the sexual assault examinations, that it does get quite complicated for you when you have more than one child who has to be examined. So that might be sometimes you have a child assailant who also needs to be referred to see a different doctor because they've had exposure to things and need their health needs met and assessed. And then sometimes within a family you will have a group of children, won't you, who also need to be examined because there might be something happening with FGM. Understanding the family construct and who else is in the family might require other children to be examined, or referral for the mother or aunts or older sisters to be examined by other doctors. So you do get that a bit of extra work sometimes just from one case, don't you?
Yeah, and I think often those cases they're rarely urgent, and taking some time to discuss with the family, help them understand why we're wanting to do an examination you know, just sort of try and sort of allay any sort of concerns. It's worth taking that time and not rushing things. I think sometimes, you know, people you know, worry that things need to get done straight away, and unless it's sort of acute injuries or forensics, and actually sometimes taking the time to do things in a way that's going to be the most sort of child-centered and least traumatic is worth just sort of taking a breath and doing some multi-agency planning to find the best way to do that. Fabulous. Anybody else or any other questions? Well, shall I hand back to you then, Jo?
Yeah, no, thank you. And yeah, just to say thank you very much, Catherine. That was really, really interesting, and I've learned a lot from that session, definitely. So as Andy's posted into the meeting chat, the slides will be uploaded onto the Welsh Sexual Assault Services webpage. The link is in the chat. And if there is anyone that wants to discuss anything they've seen today with Catherine, as she said at the beginning, then they're able to contact her if there's anything further that needs explaining. So all it is for me now is to say thank you very much for attending today. Our next workshop is next month, and Andy's just nodding at me because we're actually in the same room today, which is lovely. So we've got another workshop like next month, and we are holding them monthly. And so if anybody wants to join, please keep an eye out on Eventbrite for further workshops. And she is writing it down now. 26th. 12 months research. Okay, so it's the 26th of September, and it's the South Wales Research Network who's going to be our next Lunch and Learn session. So again, thank you, Catherine, and thank you all for joining today. Take care. Bye.